Hello again. So here's my post-operative protocol in Pittsburgh. First question was about pain medication. We do give a lot of pain medication. I put oxycodone last, but every patient probably takes for 2 to 3 days oxycodone. We gave acetaminophen, ibuprofen. My personal preference is I do aspirate relatively aggressively if there's a large effusion and the patient doesn't have a quadriceps set. Immediate post-op care is with the brace. We use a lot of post-operative bracing here for the first 2 to 6 weeks, depending on meniscus repair. A radial split meniscus gets 6 weeks in the brace. ACL and big MCL, 6 weeks in the brace. Crutches, isolated ACL, weight bearing is tolerated in the beginning, 2 weeks of crutches for 2 weeks, and then phasing out into no crutches. And I discontinue this with full equal knee extension, with maintaining a knee in full extension, and no increased pain or swelling. Muscle strength, so early activation exercises for quadriceps and hamstrings. The quad set and full hyperextension is the absolute key in the beginning, and as you all know, this predicts whether you have good or bad outcome. So I stress this already in the recovery room, quadriceps, quadriceps, quadriceps. And then progress to more open kinetic chain type of stuff. So first the leg press in the single leg, open kinetic chain, then from 90 to 60, step ups and step downs, bridges, hamstring curls, wall slides. The range of motion exercises we do early on. If flexion is limited to 90 degrees in the meniscus repair situation for 4 weeks, we do heel slides, and we do about 1 hour sessions 1 to 3 times a week. As far as patient education and support, this is a great question. I think we could do much better. Mathieu has shown super interesting AI tools. We don't really use that. But I use 3D models and I do a lot of drawings. I sit with the patient and draw pictures and make sure they understand what I'm talking about. But they have a detailed rehab protocol. We have a detailed return to sport testing battery that we do that Jay Ehrgang published. And of course, we stress the importance of follow-up. Driving, if it's the right knee, no driving for 4 to 6 weeks. If it's the left knee, they may drive once the brace is off. And then the training and programming. So the rehab is adjusted to individual needs. They get a PT and the physician and the therapist work very closely together, and we advance per return to sport testing. And then criteria for moving forward is passive and active hyperextension, symmetric, full flexion. And then, of course, the swelling needs to be decreased. So in conclusion, key is early stage rehab strategies. Focus on the quadriceps and achieving full extension early on. Don't overexert. I do aspirate, as I said, if necessary. And then individualized, high-quality early rehab. Good communication is really key between the physician and the physical therapist. I think you need to hopefully know each other and talk the same language. Okay. Thank you very much.